Today we're going to navigate the complexities of endometriosis and chronic inflammation. My name is Dr. Arianne Missimer. I'm a functional medicine practitioner, doctor of physical therapy, registered dietitian, owner of the Movement Paradigm Integrative Health Center, and I'm a medical educator for Root the Health. So today we're going to cover the general immune system and inflammation, the immune changes and inflammation that happen in endometriosis, the pathogenesis and progression of it, of course some functional lab testing, a complex women's health case study, and also some evidence-based strategies that you can incorporate. So what is endometriosis? It is a chronic condition characterized by the presence of endometrial-like tissue outside of the uterus, leading to complex interactions between the nervous, immune, hormonal, and genetic systems. This condition is influenced by neuroimmunologic factors causing inflammation, pain, and in some cases, infertility. So endometriosis affects roughly 10% of the population. So it's 190 million women of reproductive age and girls globally. It's not easily diagnosed due to the broad spectrum and variability of its presenting symptoms, including pelvic pain, pain during intercourse, psychological distress, bladder and bowel problems, and so much more, which we'll get into. So surgery is widely used for the treatment of endometriosis, but a significant risk of reoccurrence and unresolved symptoms make the disease the third most common cause of hospitalization in the U.S. And the overall reoccurrence rate is between 6% and 67%. So you can see there's a huge discrepancy here, according to the criteria that are taken into consideration. The discrepancy in the reoccurrence rate of endometriosis depends on a number of different issues. But ultimately, the other thing that we want to consider is between 30 and 50% of women with endo are infertile. So what we do know consistently is that oxidative stress has proven to be a hallmark of this disease. So the development of endometriosis involves interacting endocrine, immunologic, pro-inflammatory, and pro-angiogenic processes. However, it's not known if these factors are causal or if they represent a feature of the pathophysiology of endometriosis. So we also know that it is an estrogen-dependent disease. So compared with healthy women, local levels of estrogen are higher in the menstrual blood with patients with endometriosis. It's also considered a hormone-dependent chronic inflammatory disease. So this is usually accompanied by a high level of local estrogen and abnormal levels of cytokines. So when we're looking at the pathophysiology, we can see that there's initially these endometrial changes. So this can be associated with inflammation and impaired immune response. As we begin to have menstruation, this is going to shed tissues and cells, which contributes to this retrograde flow and also further inflammation. It can enter the pelvic cavity, and this is what contributes to impaired immune cells. Then we begin to have adhesions and implantation. So this is an influx and activation of the immune cells. Then we have lesion growth, which is, of course, associated with chronic inflammation. And then we have lesion persistence, which is going to be chronic inflammation and also symptom generation, because we do know that there are a portion of women that have endometriosis that do not have symptoms as well. So let's kind of tackle the immune system first as we move into how this relates to inflammation. So when we're first talking about our innate immunity, which is think of our first line of defense, it's a non-specific response. We have cells like our neutrophils, our macrophages, our natural killer cells, and these are going to essentially identify and attack whatever the pathogen is immediately. The dendritic cells are going to act as an antigen presenting cell. So they're going to capture the pathogen and present their antigens to initiate the adaptive immunity. When we're thinking about the adaptive immunity, we have specific responses that are tailored to the pathogen. So we have our T cells. So these killer T cells are going to attack infected cells directly. The helper T cells are going to activate B cells and other immune cells. The B cells are going to produce antibodies for pathogen-specific targeting immunity, and then they're going to also develop a long-term memory or a faster response for re-exposure. So what is the transition between the two? So the transition between the systems is that the dendritic cells process pathogens and present antigenic peptides to the lymph nodes, which is really important as we get into this later. And it's bridging the innate and the adaptive immunity. So this movement essentially is triggering the adaptive immune response to a more targeted response. When this goes wrong, this is when we can have a malfunction. So we can have allergies, we can have an autoimmune conditions and chronic inflammatory conditions. So as it relates to endometriosis, which is autoimmune-like, there's research can show that women with endometriosis actually have higher rates of autoimmune diseases such as lupus, rheumatoid arthritis, and even MS. And also they can have other immune abnormalities. So that could be anything from increased neutrophils and macrophages to elevated antibody levels to elevated inflammatory markers and reduced natural killer cells. So we can also have, which I think is really important, is this local inflammation. And so the levels and concentrations of these active macrophages like interleukin 1, 6, and 8, nerve growth factor, other immune cells, and also these inflammatory factors that are increased in the peritoneal fluid and endometrial lesions themselves are also forming this inflammatory environment. So there's so much local inflammation that's happening that I'm going to touch on when we get to our case study. So this environment interacts with endometrial cells, and this can play a huge role in the development and persistence of endometriosis. So at present, what we know is that endometriosis is thought to arise due to a variety of factors. So one, as I already mentioned, just to recap it, is this retrograde menstruation. So this refers to this reflux of the menstrual debris that are containing these viable endometrial cells through the fallopian tubes into the peritoneal cavity. We can also have cellular metaplasia. So this is where we have the transformation of peritoneal mesothelium into the glandular endometrium, and we have the lymphatic and vascular metastases, so the transport of these endometrial cells through the lymphatic and blood vessels. We also know that there's endometrial stem cell and progenitor cell populations, and these are present in the endometrium. They are being shed in this retrograde menstruation, so this may play a huge role in the development of more lesions. And then some other factors could include altered or impaired immunity, localized complex hormonal influences, genetics, and environmental contaminants. So when we're thinking about the characteristics of endometriosis, we want to recognize that location-wise, it's endometrial-like tissue that's growing outside of the uterus. It typically is going to be associated with a normal-sized uterus, but it can also be specifically associated with the uterus that's not moving very well. Its main symptom can be pelvic pain and infertility, and the diagnosis is going to be a laparoscopic surgery or imaging specifically for larger lesions. So bringing these core concepts together as it relates to endometriosis and inflammation. We have chronic inflammation at the core. So this endometrial-like tissue, again, is growing outside of the uterus, triggering a local inflammatory immune response. And also, this abnormal tissue is going to release pro-inflammatory cytokines and chemokines, leading to this chronic inflammatory state. The role of the immune system is, we want to recognize here that the immune system is often dysregulated. It is failing to clear this ectopic endometrial tissue effectively. And the presence of ectopic tissue activates the macrophages and other immune cells, and this contributes to this ongoing inflammatory process. We have oxidative stress. So the inflamed environment is going to lead to a production of reactive oxygen species. This is going to further exacerbate tissue damage and promote the release of more cytokines. We also have pain and nerve involvement. So we have inflammation, which is going to sensitize nerve endings in the pelvis. So this creates very much of a visceral hypersensitivity, contributing to chronic pelvic pain. So the nerve fibers are going to often grow into the endometrial lesions, and this can amplify pain perception. We have this hormonal influence and inflammation. So estrogen dominance can amplify inflammation. So estrogen is going to promote the production of inflammatory prostaglandins, and this can increase pain and inflammation. Progesterone resistance is often seen in someone with endo, and this is going to reduce the anti-inflammatory effect that typically is going to counteract estrogen dominance. We have adhesions and scarring. So chronic inflammation is going to promote fibrosis. So now we have these tissues that aren't gliding and moving the way that they're supposed to. So it's leading to the formation of adhesions. The adhesions are restricting organ mobility and organ motility. And this creates structural dysfunction, influencing inflammation, of course, but then also all of this congestion and stagnation in the lymphatic system. There's the systemic inflammatory impact. So even though we know that these adhesions are localized in most cases, they can contribute to systemic inflammation. Often what we see is these elevated inflammatory markers are often seen in individuals with endometriosis, and this can create a whole host of symptoms. And so as we're thinking about how to approach it, which we'll talk about later, is a therapeutic focus on reducing overall inflammation. So now I'd love to discuss some other considerations that I think are really valuable in doing a comprehensive assessment of a patient presenting with endometriosis. We want to be thinking about, when did this occur in their lifetime? Did it occur before childbirth? Did it occur after childbirth? Have they given birth? Have they had any abdominal scarring? What are the other implications that relates to their nervous system? So the first thing that I think is really important is C-sections. So a C-section is so common and involves cutting through 7 distinct layers of tissue to deliver a baby. And so oftentimes what I've seen is that the patients that I've treated with endometriosis have had a history of a C-section as well. And so when we're thinking about this depth of tissue, they're cutting through the skin, then the subcutaneous tissue, then the fascia, then the muscle, cutting through the rectus abdominis, then the peritoneum, which is that thin membrane lining the abdominal cavity, then the uterus, then the amniotic sac. So after delivery, these layers are actually repaired in the reverse order in most cases. And so this is really important because this is going to have a profound impact on the mobility, motility, and lymphatic and venous flow in the pelvic cavity. So it's something we really want to take into consideration. Also, we want to think about a malpositioned uterus. So this is also something that can be extremely valuable in understanding whether this is congenital or this is actually due to potentially restrictions in the tissue. But for example, in a retroverted uterus, there could be 3 degrees of different retroversion. And so this can be significant because the uterus is really meant to move during hormonal fluctuations. And if it's not really moving, then we're not really getting good, again, venous and lymph flow in this area. So although sometimes this can be completely asymptomatic, it also can be the cause of pelvic pain, lumbosacral pain, dysmenorrhea, infertility, repetitive miscarriages. And so there's a lot of things that we want to think about is most importantly recognizing that the uterus is meant to move, and it's meant to move during our menstrual cycle, and any abnormal tension in this area can create tension on specific ligaments like the pubovesical ligament, which can create a lot of tension and poor movement and ultimately symptoms. So we want to factor something like this in as well. We also want to think about the involvement of the vagus nerve. So I love to talk about the vagus nerve, but in this case, it plays a pivotal role in regulating inflammation and balancing the immune system. So chronic inflammation, as we know, is going to exacerbate pain and tissue damage, which is what's happening in the case of endometriosis. When we're looking more specific at the anatomy, the posterior vagus nerve is actually integrating with a network of sympathetic plexi, which is our network of nerves, and that's specifically the celiac plexus, the superior and inferior mesenteric plexus, and then the superior and inferior hypogastric plexus. So this plexi actually forms this integrated circuit, which is going to move blood flow in and out of the pelvis. And this is exactly what the autonomic nervous system does, which is moving blood flow in and out of the area. So the network of nerves is where the vagus nerve is going to bring blood flow back to the heart and brain. And when we're thinking about women's health, for example, we want to think about urination and defecation and having an orgasm ultimately requires a complex integration of all of these nerves and proper blood flow to the area and vasodilation to be able to communicate with the pelvis and the rest of the body. And so as it relates to the vagus nerve and how specifically it controls inflammation, it's 2 key ways. So the first is going to be the signal to the spleen, which is one of our main lymph organs. So when the vagus nerve is active, it's going to send signals that cause T cells, which is basically a type of immune cell, to the spleen to release acetylcholine. So this is a chemical messenger or neurotransmitter that helps to reduce inflammation. So this process is also involving noradrenaline that works with acetylcholine. It also has a direct effect on other organs. So in other parts of the body, the vagus nerve is going to directly release acetylcholine from its nerve endings to calm down inflammation. So acetylcholine is going to work by, one, blocking the movement of NF-kappa B into the nucleus of the immune cells, and that's ultimately going to prevent the production of inflammatory signals. And then two, it's going to activate a specific pathway that reduces the inflammatory molecules. So in short, the vagus nerve is going to use acetylcholine that acts essentially like a brake on inflammation. That's the best way to think of it. It keeps the immune system from overreacting and causing more damage. So as it relates to lymphatic congestion and stagnation and how it can ultimately perpetuate symptoms, we want to think about this increased inflammation is going to impair lymphatic flow, preventing the clearance of inflammatory cytokines. So this is going to lead to chronic inflammation in the pelvic region. Also toxin accumulation. So stagnant lymphatic flow allows toxins and metabolic waste to build up, which worsens the systemic and local inflammation. Hormonal imbalance is when we have reduced lymphatic drainage, it's going to interfere with the excretion of estrogen, contributing to further estrogen dominance, which can exacerbate conditions. Tissue swelling and pain. So we often see urogenital pelvic congestion, and so lymphatic fluid is going to essentially build up, creating heaviness and swelling and pressure in the pelvis, often amplifying pain and discomfort. And congestion is going to reduce the lymph node activity, impairing the immune response and the body's ability to manage this inflammation and repair tissue like it should in our normal defense and repair mechanism. And then also we have fatigue and heaviness. So the systemic lymphatic stagnation, often we will see even, lots of leg swelling, especially during menstruation. This can contribute to feelings of fatigue, pelvic heaviness, overall sluggishness as well. And we also, of course, want to factor in estrogen dominance and detoxification. So our pathway of estrogen excretion involves the lymphatic system as well. So in phase 1 and phase 2, which happens in the liver of detoxification, we have estrogen that's metabolized in the liver through phase 1 and phase 2, so hydroxylation and conjugation processes. During phase 2, estrogen is converted to the water soluble from more of a fat soluble form via glucuronidation, sulfation, or methylation, ultimately preparing for its excretion. This is going to be transported via the lymphatic system. So after metabolism in the liver occurs, we have some estrogen metabolites that are transported into bile, and this is going to drain into the small intestine for excretion through the feces. That's our phase 3 detoxification. We also have excess estrogen and its metabolites that enter into the interstitial fluid, which is basically the fluid surrounding our cells, and this is what the lymphatic system helps to collect and transport. So the lymphatic system moves these metabolites to lymph nodes and eventually into the bloodstream for filtration and final excretion. And so when we have these clearance of estrogen metabolites, we basically are having them eliminated via feces, which we have beta-glucuronidase that we look at in our stool test specifically. Most estrogen metabolites are going to leave the body through bile and fecal matter. We have urine, which some are going to be filtered in the kidneys and then excreted via the urinary system. And then once again, the lymphatic flow, which is the lymphatic system, facilitates detoxification by preventing buildup in tissues and aiding in overall circulation. So hopefully you can appreciate all of the complexities as it relates to endometriosis and inflammation, and also specifically the involvement of the lymphatic system. So now we're going to move into some lab testing that you can do, because as I mentioned earlier, really the gold standard of diagnosis is a laparoscopic surgery. So we want to be looking at the whole person as it relates to root cause medicine. So from that perspective, we know that endometriosis is hormonally influenced, and we also know it's greatly associated with inflammation. So this is a really great starting point, is what are the factors that are contributing to these potential hormonal imbalances, as well as inflammation in the person or patient that we're working with, or if this is for you and you are working with your provider and you really want to understand root cause medicine, these are some things that you can inquire about. So we can look at a Dutch test. So this could be really great for a comprehensive look at your hormones to assess your estrogen, your progesterone, your testosterone, your estrogen metabolites, which can be really, really powerful as it relates to phase 1 and phase 2 detoxification, as well as cortisol patterns, which I think is extremely helpful. We can also look at serum testing like FSH, LH, estradiol, progesterone to evaluate the cycle and hormonal balance overall. And of course, our androgens, DHEA, testosterone, sex hormone binding globulin as well. So we can look at inflammatory markers. We know that systemic inflammation is a hallmark sign. So high sensitivity CRP, which is measuring systemic inflammation, erythrocyte sedimentation rate, which is indicating chronic inflammation, a cytokine panel, which can assess pro-inflammatory markers. We can also look at gut health and dysbiosis. So this can be extremely valuable because the microbiome is significantly impacting inflammation and estrogen metabolism. In fact, it is 70% of our overall immune system, especially via the gut-associated lymphoid tissue. So we can do a comprehensive stool analysis, so something like the GI map or doctor's data or Genova GI effects. This can evaluate everything from dysbiosis, pathogens, short-chain fatty acids, inflammatory markers like calprotectin, also zonulin, so looking at a intestinal permeability or leaky gut. We can also look specifically at beta-glucuronidase, which is going to indicate impaired estrogen detoxification in the gut, which is what I see so commonly with endometriosis. And then, of course, detoxification and liver function. So we want to be able to look into phase 1 and phase 2 detox pathways. So we can look at our basic liver function test, and that can evaluate overall liver health like ALT, AST, bilirubin, GGT. We can also look at methylation pathway markers like homocysteine and folate and B12, even SAMe levels. And then we could do more specific advanced lab testing like toxin exposure. So this could be heavy metals, mold and mycotoxin testing, environmental toxins, and so on. Nutrient status. So nutrient deficiencies can worsen inflammation and hormone imbalances. And we know that over and over again with so many different conditions. So we want to be able to look at things like vitamin D, omega-3 and 6 ratio, magnesium, zinc, selenium, B vitamins. All of these could be really valuable in understanding a complete picture. Autoimmune and immune markers. Because there is a high percentage of people that have endometriosis that may have other inflammatory conditions, we can also look at an ANA, so anti-nuclear antibodies to screen for autoimmunity, anti-thyroid antibodies, and also, of course, a complete thyroid panel, and also something like natural killer cell activity to look for relevant immune dysregulation. Estrogen and metabolism, so we talked about doing the Dutch test, and this could be really helpful when we're looking at more of the metabolism of estrogen. So we can look at estrone, estradiol, estriol, and measure levels of different forms of estrogen. And we can also do something like a organic acid test. So this is going to evaluate for mitochondrial function, oxidative stress, and detox pathways. And then we can do something like genetic testing. So I personally, with my patients, use the 3x4 genetic test, which I find extremely valuable, and just understanding and looking more upstream. How are they detoxifying? How are they managing oxidative stress? How are they managing inflammation? And even from a vascular component, there's so many layers that we can really understand. And you could also do, of course, individual genes as well. So looking at MTHFR, you could look at the COMT gene, CYP genes. So all of these can have, positive information as you're putting together a case. And then others might include things like food allergy testing, celiac testing, looking into histamine intolerance and evaluating that in more depth, especially with its relationship to estrogen dominance. And then you can also do something like a detailed micronutrient test like NutriVal. That's a comprehensive panel that can really look at intracellular nutrient deficiencies and so on. So it could be really valuable. So I'd love to move into a case, and this is a patient that I had worked with who is a 34-year-old female presenting with adenomyosis and endometriosis, severe dysmenorrhea, traumatic C-section, fertility issues. And she had been working on quite a bit of things with other practitioners. So she was, taking different supplements, and she had done some different testing. And what I wanted to focus on for this purpose of the case study is basically how we began to address physically what was going on from a local immune response aspect. So she was having so many symptoms, from pain and scar tissue and inflammation. She had movement limitations, and her lab testing did reveal elevated CRP. She had elevated estrogen. She had decreased vitamin D. So there were definitely some labs that were involved. But again, she had been working with another provider, so I was coming into it from a different perspective. I wanted to kind of take you through a little bit of her symptoms. So she had abnormal cycle. So she did have a 28-day cycle, but she was spotting pre-period and post-period. So pre was about 2 to 5 days of brown spotting, post-period 1 to 2 days of light spotting. Her bleeding pattern was 5 days of bleeding with significant clots. She typically had pea-sized clots, occasionally quarter size, and dark red to purple, of extremely, extremely heavy flow. Debilitating symptoms on day 2, but she would wear a menstrual cup, and she had to wear period underwear. She would empty the cup pretty frequently. She had severe cramping during her periods, which, like I said, really were debilitating, where she really felt like she couldn't get out of bed. Significant fatigue, tender breast, irritability, bloating, swelling in the abdomen and legs, and quite significant, especially during her menstrual cycle. She had to change her clothing based on that. She had position-specific pain during intercourse, so she could not tolerate posterior penetrative sex. She also had pain with full insertion, and she also had bleeding even while using a lubricant, and she always had to use a lubricant. She also had infertility. So this was what she was dealing with now. So she had her son via a traumatic emergency C-section, and then she had 2 different miscarriages. So she had chemical pregnancies, and she was doing IUIs, and she had 2 rounds of that. The 3rd round was canceled because she developed a significant ovarian cyst, and also her estrogen levels were skyrocketing. She also would have different coffee-triggered urgency, so some bladder irritation depending on what was going on. She had coccyx pain with forward bending, and she also just had this urogenital pelvic congestion, so heaviness, discomfort, pain, pretty significant. So what we did was actually, through physiotherapy, we did a very specific treatment based on visceral mobilization and lymphatics. So based on her assessment, I found that her bladder was not moving very well. Her uterus was not moving at all. And in fact, she did have a retroverted uterus. So this was really a really important part of her history, because she did know that early on. We're not sure if that was congenital or if that was part of her history with the C-section and everything else. She also had very, very, very tight ligaments, especially the pubovesical ligament, which is attaching to the uterus. So we basically treated all of these things through a visceral manipulation approach. These are very, very targeted treatments towards creating some mobility and motility in the organs and the ligaments. And so we basically, in that session, or the first session, targeted her sacrum, her coccyx, her sacrotuberous ligament, her sacrospinous ligament. We also used something called lymphatouch, which is a precision-based negative pressure therapy, to begin to address her scar, her C-section scar, which was extremely restricted. And of course, we integrated this with breath and movement. After her first session, with 1 week later, she reported less pelvic congestion, much less swelling during her menstrual cycle. She had significantly less bloating. So she had 4 days of spotting still. She had 4 days of bleeding, but it was not as heavy. And she did not need to empty the cup as often. And her coccyx pain totally resolved. And she also had intercourse 3 times since we had met. And she had less fullness and heavy sensation in the abdomen after she had an orgasm, which was one of her complaints. She did not have any rectal pain, and she had no symptoms, which was really amazing. For the treatment too, we really focused in a little bit more on the uterus and the broad ligament, which we found to be extremely restricted. So the broad ligament is going to unite the lateral borders of the uterus to the lateral walls of the pelvis. So there's neural and vascular components to this. So we actually worked on that, which was really, really powerful. We did, again, some scar work and in the abdomen. And then we also did a little bit of lymph work in the lower pelvis, and we did that on a slightly different setting. And so after session 2, the tailbone pain was still resolved. She was able to have sex with rear entry. She did not report any spotting, and she had also increased lubrication, so she did not have to use any lubrication. After treatment 3, we assessed the round ligament. So the round ligament was also found to be very restrictive, and this is typically going to be associated with that pain at penetration. And we also worked on some mobility and motility of the uterus. So really trying to still assess that retroverted uterus. It wasn't moving very well at all. So we were trying to really understand, is it side bent and so on. We also did a little bit more of, as related to the lymph that day, a little bit more of a pulse setting to just focus on the overall lymphatic flow. And after that session, she had her period. This was really profound. So significantly less pain, so 2 out of 10 versus an 8 or 9 out of 10. Clotting was significantly less. She spotted one day. She started right into a flow versus kind of a slow drip, as she explained. It was heavy, but it was red. Normally it is not. She had significantly less bloating. She was annoyed that she had her cycle, but she was not debilitated. And she had so much less swelling during her period in the abdominal cavity, as well as even her legs, which, again, she was normally not able to wear certain pants or clothing. And so in the last session, we again just kind of went back to the uterus and really tried to understand what was happening there. And there definitely was some restrictions in terms of how the uterus was moving. And the key thing is that the uterus just needs to move. If it's side bent and it's not moving, even if it's retroverted, it's okay. It just needs to be able to move. And so we specifically worked on that aspect of it. We worked on the fallopian tubes slightly, and we found that all improved. And so just to give you an idea, if you can look at this picture on the left versus the right, this is just after 4 sessions, just to give you an idea of, if you can see in her abdomen, especially on this right side, this is where she had so much, where her tattoo is. She had so much swelling here, and you could see kind of how just overall her abdominal cavity was just extremely congested. And so we, after doing just 4 sessions, really were able to improve the whole tone of the abdomen, decrease some of this congestion, even out the scar as well, which was really powerful. So we made significant progress on this, which was really amazing. So what we can see by this, which I think is a really valuable aspect of treatment to be considered, is the implications of the lymphatic system and the viscera. So the lymph vessels around the viscera are going to drain this interstitial fluid, toxins, inflammatory mediators from the organs. And so when we have this impaired lymphatic flow due to fascial restrictions, due to scar tissue, it can lead to more congestion, inflammation, and pain. And so if we can optimize the lymphatic flow to support detoxification, reduce swelling, enhance immune function, we can potentially make quite a bit of change here. And so I mentioned this a couple times, but we want the organs to have proper motility, which basically means this physiological rhythm of the organ, such as peristalsis and diaphragmatic breathing. So we have that inspiration and expiration, and we can see that rhythm of the diaphragm, for example. We have this with each organ called an inspire and an expire. And so in mobility, just like all of our other skeletal muscle system, we want our organs to move as well. And oftentimes they move about 2 to 3 centimeters based on our breath. And so the ability of the organs to move freely within the abdominal and thoracic cavities is extremely important and influenced by our fascia and our ligaments and our adjacent organs, which is why all the work that I just shared with you in terms of how we address very specifically what was happening for her made such a huge difference in such a short amount of time. And the restrictions, it can lead to adhesions, impaired organ function, of course, and inflammation. And just so you can get an idea of what the mechanical decompression looks like as it relates to the LymphaTouch that we use for her treatment, essentially it is that precision-based negative pressure. So it's pulling the tissue and it's activating the lymphatic and circulatory system. So you can see here that this is an inguinal lymph node and the superficial and deep fascia during the LymphaTouch treatment. So ultimately we're creating a really, really powerful result. And then when we're adding vibration, it can activate the superficial and deep tissue layers, and it ultimately can relax and soften these layers as well. So now let's move into pulling this all together with some evidence-based strategies. So the first is going to be in adopting an anti-inflammatory diet. So this can emphasize a Mediterranean-like diet, fresh vegetables, fruits, seeds, nuts, whole grains, healthy protein and fat sources, and this may be helpful in the management of endometriosis. This may look very specific for each person, depending on if there's specific food sensitivities or specific food intolerances or celiac disease or allergies, but ultimately we want to try to adopt an anti-inflammatory diet. Hormonal management. So hormonal treatments can help to regulate estrogen and progesterone levels, and this can be really valuable in the treatment and management for the condition. So of course, this needs to be evaluated thoroughly and then could potentially be treated with hormone replacement. It could also be managed through supplementation, but this would need to be assessed in each individual. Incorporating omega-3 fatty acids. So this can have an anti-inflammatory property that may help reduce the endometriosis-related inflammation. And this could be really important as it relates to getting in enough of this during the day. And during your week. So most often we are clearly very deficient in omega-3s and have an imbalance in our 3-to-6 ratio. So that's why we want to use that as a testing measure as well. Maintaining high antioxidant intake. So often we're taking things out of our diet, and really we need to be thinking of how can we add in things to our diet? How can we promote this high antioxidant, high polyphenol diet? And this can help neutralize oxidative stress. So instead of always thinking about taking out, let's think about what we can put in. So thinking of our berries and all of these wonderful polyphenols, green tea, and so on. Consider vitamin D supplementation. First, make sure to get your levels checked. You should have this checked regularly every year, at least once a year, to monitor your levels and make sure that you are getting an appropriate amount via your supplementation and, of course, sunlight. And really emphasizing this because it can have a huge immunomodulatory effect that really may benefit as it relates to this condition. Physiotherapy. So I talked so much about this in this specific case, and of course there were so many other things that were involved in her specific case, but I really wanted to highlight this amazing opportunity that we can have if referred properly. And so this can be ranging from a variety of techniques, from manual techniques to lymphatic techniques to visceral mobilization and pelvic floor therapy, making sure that you're referring to a qualified practitioner who really understands all of this and how to put all of this together, because it's really important that we look at the individual in front of us and make sure that we are taking all of this into consideration to give them the best quality care. And some others that we want to, of course, consider are exercise. Exercise is challenging because I do want to make sure that we are considering that this can be a chronic pain or chronic central sensitization issue, in which case we need slow graded movement. If someone is experiencing no pain at all and they're completely asymptomatic, this might be completely irrelevant. But I do want to factor that in where you might say, oh, I've tried to exercise and I just feel like I can't. That's understandable. Ultimately, exercise is going to be one of the most powerful things for our mitochondria, our health, our ability to regulate inflammation, our gut, and so much more. But it has to be done in a graded and safe way. So I do advise working with a practitioner to help guide you on that journey. Of course, making sure you're getting adequate sleep. So this doesn't mean just are you getting enough sleep, but also are you getting good quality sleep? Are you getting enough deep? Are you getting enough REM? Do you potentially have signs of an airway disorder? In my clinic, this is one of the things I screen for all of the time. And so often I see upper airway resistance. I see mild sleep apnea. I see mouth breathing, snoring. And in which case, these are all signs of an airway and sleep disorder, which means that you're not getting good quality sleep. You're never able to restore, and your body will always be in a chronic dysregulated immune state and also high cortisol state, which leads me to the last one, which is stress. So if you're experiencing chronic stress, whether that is potentially just day-to-day stress, whether that is something that you have not dealt with, maybe that is something that you've experienced as a child, all of these things are going to influence the way that you are able to manage your daily stressors and your life stressors and overall your resilience. And so what happens is when we have this chronic stress that causes chronic inflammation that changes actually the bacteria in our gut, that creates this chronic release of cortisol, and then ultimately that cortisol will start to tank, and then we feel really tired and have salt cravings and feel like insomnia and so much more. So we want to factor in all of these other really important variables as a comprehensive approach to endometriosis. So in summary, we want to remember that chronic inflammation is a hallmark of immune dysregulation, contributing to pain and tissue damage in endometriosis. These altered immune responses include increased pro-inflammatory cytokines, impaired macrophage activity, and this localized inflammation is going to exacerbate the lesion growth and progression. As it relates to pathogenesis and progression of the condition, we have these dysregulated immune responses that drive this endometrial-like tissue outside of the uterus. The lymphatic congestion, the vagus nerve dysfunction, the oxidative stress are all going to play a key role in this. And as you saw from our case study, I think it's really great to emphasize how these local vascular manipulations that are performed can influence a general increase in venous return to the abdominal cavity. The fascial tension can compress these lymphatic vessels, so impairing drainage, creating a feedback loop of inflammation and nerve irritation. So you saw from that picture in such a short amount of time how we were able to influence her lymph and venous flow so well. This nerve dysfunction from fascial or lymphatic restriction can disrupt the visceral motility, further influencing the endometrial dysfunction. And we can address all of these holistically and ensure that we're improving the mobility and motility of the viscera and that it's sustained and optimized. And then as it relates to lab testing, there are so many different lab markers that we can look at to look at the bio-individuality of the person that we're working with. Or again, if you're watching this video and you want to come to your provider, please reference all of these biomarkers that can be extremely helpful for understanding you and what you're dealing with. And then lastly, these evidence-based strategies such as anti-inflammatory nutrition, vagus nerve stimulation, lymphatic drainage, hormonal imbalance, exercise, sleep, and really just trying to bring balance and addressing endometriosis not just as a specific disease, but really addressing it from this bio-individual approach. I hope that you found this helpful. Thank you so much for joining me today. If you want more videos like this, please subscribe to our YouTube channel for more videos on root cause medicine.
Welcome to Root the Health, the best place to order, manage, and track results from over 30 different lab companies in one single place for free. It's going to take you under 2 minutes to sign up, and you can order any functional medicine lab for your client in under 30 seconds. Let me show you how it's done. So here's our beautiful interface. I'm typing in the name of my client, selecting the lab that I want to order for them, and hitting send. From there, Rupa and their amazing team handle the rest. They email the client, collect payment, and even offer an interest-free 3-month payment plan. We've also built the world's largest library of information about chronic health conditions, the lab tests that can help you find the root cause, and the evidence-based interventions that you can use to help people heal from them. It's called the Rupa Health Magazine. There, we have in-depth articles about almost any health condition you can imagine. And we give you step-by-step protocols that other clinicians have used to help their clients heal and that are verified by evidence-based sources. You should totally check it out, and it'll transform your practice. And we can't wait to see you. So make sure you sign up today at rupahealth.com.